Professor Shahid Shamim. He is a professor and director of postgraduate studies, Faculty of Surgery at Aga Khan University. He is PGD Bioethics, MHPE and PhD in medical education. Professor Shahid Shamim.
Thank you very much. When I was called for this talk, it was 20 minutes. Then when I came here, it became 15 minutes, then 10 minutes, and now I've been told that in 10 minutes that we have two speakers, so in 5 minutes I have to finish my talk. So I've hidden most of the slides. I'll just go from the beginning, a few slides in the middle, and then suddenly you'll see the conclusion slide, so please don't mind that. So we have been talking about training and training of colorectal surgeons, and I think it's really heartening to see that we are talking about training, because I think and my talk is about training surgeons for 21st century. What is 21st century? It's the time from January 2001 when I started my career as a surgeon after doing my fellowships, and it will go up to 2100. I'm sure many of us would not be here to see that, but we are training surgeons for 21st century, while we were trained in the 20th and 19th century by the ways that were created in probably 18th century or before. And things have moved on after that tremendously. We are talking about colorectal surgeons. We are talking about people who are, we are talking about trainees who question now, not like the trainees who used to just keep their head down and do whatever they were supposed to, they were told to do. And we are talking about professional demands where, the disease processes has changed, the treatment plans have changed. We go by the book now, we go with, it's not on the whim of a surgeon who would decide what to do. It has to be a multidisciplinary team which decides. The apprentice is no more a loyal apprentice like a loyal dog. You kick him, you hit him, you abuse him and or her. Well, they were not surgical trainees heard at those times, but now you see a lot of females, girls, very, very dedicated and motivated female surgeons we are going to be seeing in future, and we are still seeing now also. So, and the professional demands have changed. Research and technology has taken a lot of things over. So the skills that we need to impart to our trainees in 21st century are not just surgical skills, are not just operative skills, because they have become like mathematics now. If it's a T1 N0 tumor, this is what you need to do. If it is a T3 tumor, this is what you have to do. But there are so many other things that you need to give to them, which probably never were thought of in the 18th and 19th century, but for the 21st century, they have become necessary skills that needs to be given to trainees. Like Socrates developed Plato, and Plato developed Aristotle, and all of them developed Alexander the Great. I mean, somebody who had never picked up a sword is developing a person who is conquering half of the world. This is what mentoring is. And to create someone like that, we need to have people who know how to mentor others. It's not just supervisors. CPSP registrar is here, and I'm so glad to see him. It's always a pleasure meeting, sir. But we need to come out of this one supervisor, one trainee arrangement, because that was 18th century apprenticeship model, which we kind of twisted into kind of a structured training program. But it is not a structured training program, because structured training program needs a structure. It needs something which holds everything together, and which needs different pillars, not just one pole. So, and when we talk about mentoring, we need people who can support self-assessment. Mentoring does not need to have it's not about assessing your trainees. It's about equipping them to assess themselves. It's about professional maturation. It's about psychosocial functions. And on top of everything, I think it's about reflection and feedback. We need to have trainees who can reflect, who can take feedback and reflect on that and work on that. And for that, how mentoring paradigm has changed. Even mentoring paradigm has changed over time. Like in 20th century, when I was a trainee, the mentoring means somebody was trying to add value to my training, but now it's a responsibility, it's a necessity. It's a requirement. It should be a professional requirement. The accrediting bodies should create this requirement. It's a reciprocal relationship, not a top-down approach, not like a professor teaching or kicking out a training. It used to be a one-to-one approach, one supervisor, one trainee, one mentor, one trainee. But now there's so much width and there's so much breadth in the training, in the specialities, that it is impossible for one person to be an expert of everything, except for Dr. Tehsin's friend, who is a cricketer and does everything well. But there are such good surgeons in every hospital, in every unit, but they are experts in their own fields. Expert in one field does not make him an expert of football, cannot be teaching cricket. Or expert, a bowler cannot teach batting to even in one game. So in surgery also, it has become so wide that we need multiple trainers, we need multiple mentors rather than one supervisor taking the person throughout his training process. And mentoring or training used to be early in career, and then but now, as Dr. Tehsin is saying, that people call me, people call Dr. Tehsin, people call all of us from different places, and I call my supervisors who are now retired people, and I take their advices, and this is a lifelong process. So it's not about having one supervisor or having supervision for from one person or in one place also. Like somebody was saying here that different hospitals are doing different things in a very, very tremendous way. And so whatever is, why can't our trainees go to different hospitals for their training? Why can't they train? Why do the training has to be just stay within one hospital, one unit with one supervisor throughout his training career or her training career? Why can't they visit Dr. Tehsin and Dr. Sumro and Dr. Kamran and everybody in the city or maybe outside the city for getting that particular competence which they can get best from that place? So as I said, that I'll jump to the conclusion slide as soon as possible. So we need to understand the roles of supervisors and mentors. We need to be very clear on how gender, age, time is a very important issue, because we talk about a large pool of patients and diseases in public sector hospitals. But the problem in public sector hospitals is the work starts at 8:30 in the morning and finishes at 1:30 in the afternoon. You cannot train people in 4 hours of working, and especially when you have 4 or 6 residents and fellows working with you. So maybe if we cannot increase the number of hours because of the system, maybe if we can increase the number of trainees, then that problem can be sorted out. So we need to think about these things and how these things can be addressed to get the best out of it. Yes, supervisors can also act as mentors. It is practical, but can we have more mentors? Can we have different people mentoring for different things or different procedures or different expertise, bringing expertise? And the benefit, mentoring brings the benefit for trainees, and it is very good for career progress and academic progress, but you need supervisors also. We have to think about people who can be supervisors, people who can be mentors, and we have to have a pool of them. And that change is going to bring the change which we require in the 21st century for the skills that our trainees will require after we are gone. And they would be making trainees, making surgeons for 22nd century, which will probably have more challenges. And this tree can only flourish, or we can only take it forward if we have a combination of supervisors and trainees and monitors, mentors, and different places. And that is something I think that we need to start thinking about. And I'm sorry for going so fast, and so I don't know if the message has gone across or not, but the take-home message is that the way we are training our trainees at this point in time is 18th century programs, maybe slightly modified here and there, and to go into the 21st century and taking it forward into forthcoming centuries. I think we need to relook on our training programs. We need to relook on our rotations. It has to be collaborative. It has to be with a number of mentors and supervisors for everyone. Thank you very much.
Thank you, Professor Shamim.